I'd like to welcome everybody to the Gynecologic Cancer Initiative research rounds. I'm Blake Jelks, and I'm here at Diamond Center. And we'll start by acknowledging that I'm calling in from the traditional, ancestral, and unceded territories of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh nations, and encourage you to take time to acknowledge the territories you're joining from today for our virtual arm. If you are joining virtually, I encourage you to consider coming and joining us in person again. We have delicious food, including gluten and dairy-free options, vegetarian options here, and more importantly, a chance to speak to the presenters and your colleagues, something that's not really possible online the same way. So I will now go ahead and introduce our visiting speaker, Dr. Lars-Christian Horn, who is a pathologist and clinician scientist from the Institute of Pathology and the Department of Gynecologic and Perinatal Pathology at the University of Leipzig and Leipzig University Hospital. He is part of a team there that is quite renowned worldwide for their work in gynecological cancer. And at the most recent International Gynecologic Cancer Society meeting, his colleague Michael Hochul, senior surgeon, was awarded a Lifetime Achievement Award by the International Society. And Lars-Christian has complemented that surgical expertise and approach with a very rigorous approach to diagnostic pathology. And it's a pleasure to have him here and hear about his research work. So over to you, Dr. Horn.
Thank you very much, Blake, for the introduction. And I switched it on, yeah, I switched it on. It's on, it's on. Thank you very much for the invitation. And before we go to the scientific data, I would like to introduce myself and introduce also the city of Leipzig and Leipzig University Hospital, because a couple of people asked me during the last weeks, where are you coming from, where is Leipzig situated? And there are a couple of features in Leipzig. I will touch them very briefly. Leipzig is situated in the eastern part of Germany. The city itself was established in 1015. It's an old city with a huge history, and we have about a little bit more than 600,000 inhabitants. It's a little bit comparable to the size of Vancouver, not of Greater Vancouver, but Vancouver itself. And as I said, it's located in the eastern part of Germany, about a 2 hours drive southward of Berlin. Here is about Berlin, and here is Leipzig, located in the state of Saxony. And Leipzig has also old university, and the university itself was established in 1409 as the second oldest university in Germany, and we have roughly 40,000 students, and the medical faculty within that university was established 3 years later in 1412. And Leipzig is also known in Germany for the so-called peaceful revolution, because the changes which resulted in the break of the wall started in that church here. And here you see a huge demonstration which were in Leipzig on the streets every Monday. So it's also called the Monday demonstration. And the results of these huge demonstrations resulted in the opening of the borders of the former East Germany and the reunification of in Germany. And Leipzig is also well known for Porsche cars, and these cars are built only to order. And a lot of them I saw here at the streets of British Columbia, and maybe one of these cars will the next car of one of people is listening to this presentation here. And Leipzig is also rich of history regarding culture. In 1212, there was a boys' corps established the so-called St. Thomas core. And one of its most famous leaders was Johann Sebastian Bach, who worked here a lot of years, and the time at Leipzig was one of these productive years ever. And what we also have, we have New Zealand over there. There's Amy. It's not real New Zealand, but it's Neuseeland. It means that a lot of new lakes were established surrounding Leipzig, especially in the southern part, and south of the city located in old open cast mines. And these casts were floated, and this floating resulted in a lot of lakes. And because they are new, we call them Neuseeland. It's similar to New Zealand. And in Leipzig, established in 1992, is also a very Gothic meeting. More than 20,000 people are coming to Leipzig. Visiting Leipzig is also mentioned in the New York Daily News. And also older people, younger people, and quite young people attending that meeting. And it is also very famous for his so-called Victorian picnic. This is held every Friday on Pentecost. And Leipzig is also a city of sport. We have a good team in the so-called Bundesliga. It's like a Premier League comparable to England. And it's the first marathon competition in Germany was held in 1897 in Leipzig itself. And we have a Leipzig marathon each year in Leipzig. But we have also a university hospital and a cancer center with a lot of patients are treated in our hospital with a lot of employees carrying the patients and also teaching our medical students. We have a huge medical school over there, and we are also involved to teach the students in Leipzig. And one of the scientists in Leipzig won the Nobel Prize of Medicine in 2022, Svante Pääbo, for his research on Asian bones, the Neanderthaler, and his connection to the African people and where come the people from Europe are coming from. And for that research, he won the Nobel Prize in 2022. But we have also a pathology department. This is the building, the pathology building. It's not the whole pathology compared to the Northern American system. It's the anatomical pathology only. And the anatomical pathology is situated in that old building. This was built in 1890 and destroyed during World War II, partly here in the upper part. You see the newer one in 1943. And we serve about 65,000 surgical cases and 350 autopsies each year, and we have about 10 senior pathologists and 13 residents who had to care these stuff each year. And then let's go to the research. My focus in Leipzig is the lower female genital tract and its tumors, especially squamous cell cancers. And we are looking for the crosstalk between the tumor cells and the surrounding stroma, because each cancer, when it's developed in every organ, produces some peptides, cytokines, and growth factors, resulting in a degradation of the extracellular matrix and also resulting in a stromal remodeling. This is not a new finding. It was also discovered in the very famous experiment of Peyton Roux in 1911. And he has observed that the oral infection with the RSV-2 virus, there is no tumor development within the cheeks. But if there is an injection of this virus, there's a tumor development at the site of injection. And Later on, it was discovered that the alteration of the tissue, it means the alteration and the damage of the tissue at the site of the injection is a precondition for the tumor development. And it was a pathologist in 1986 who said that tumors are similar to wounds, and tumors are wounds that never heal. And the crosstalk between the tumor cells and the surrounding stroma, so-called peritumoral stromal remodeling, one of the main feature is a change of the fibroblasts, which are common in the connective tissue surrounding any epithelium surrounding and within any organ, switch to activated fibroblasts inside the disease. And if there is an invasion, it means that the tumor breaks through the basement and goes into the surrounding tissue, especially in epithelial cancers, it means carcinomas. There is a switch from the activated fibroblasts in the cancer-associated or myofibroblasts. And what we know is there are two major things within the peritumoral stroma. Some parts of the peritumoral stroma is pro-tumorigenic. It means that the infiltrative growth is supported and increased by the alterations of the stroma surrounding the tumor cells. But on the other hand, there's also an anti-tumorigenic part of the peritumoral stroma. And the main players in the pro-tumorigenic stroma are the cancer-associated fibroblasts. And the main players within the anti-tumorigenic tumor alteration are inflammatory cells. And that there is any change between or within the peritumoral stroma, it was observed in 1876, and Dr. Beigel gives this schematic illustration in his book. And here you can see epithelial tumor, carcinoma of the breast. And he illustrated within the surrounding stroma some desmoplastic change. I will come to this thing in a minute. And it was also described by the well-known gynecologic pathologist Robert Meyer in his book from 1930. And here is a figure of a squamous cell carcinoma of the uterine cervix. And the tumor cells are surrounded by some stromal alterations. And we can see this peritumoral stromal alterations also on the microscope. Here's a squamous cell carcinoma of the uterine cervix. This is the tumor, squamous cell carcinoma. This is the normal cervical stroma. It's pink, and the stroma immediately surrounding the tumor cells are looser fibroblasts. There's an intercellular edema, and this is called desmoplastic change. And this is also important for the so-called silver pattern, which is used or has been replaced the traditional grading system for adenocarcinomas of the uterine cervix. And in the different patterns, the so-called silver patterns, pattern A, B, and C, there is an increased stromal remodeling from pattern A to pattern C. Here you can see the tumor glands, and there is only a limited alteration surrounding the infiltrative growing glands of this adenocarcinoma. Here's a little bit more increase, a limited stromal remodeling, and strong stromal remodeling is seen here in the so-called pattern C. And the different patterns have also prognostic impact, because from pattern A to pattern C, there's an increase of the frequency of lymph node involvement. There is an increase of the stage of the disease, and also the recurrency is statistically associated with a different growth pattern. And within these different growth patterns, there's also an increase of the destructive growth of the tumor cells within the cervical stroma. And there's also an increase of a peritumoral stromal remodeling. And that the microenvironment is important, as David Huntsman mentioned with its talk on October 30th at the Life Science Building at the UBC. And thank you for this slide. And once again, the peritumoral stromal remodeling in vulvar squamous cell carcinoma is similar to that in cervical carcinoma. And there is antitumorigenic stroma. It means a huge inflammatory response to the tumor cells. And here not. This is a pro-tumorigenic tumor stroma surrounding the tumor cells. And this alteration, it means the switch from the silent to the cancer-associated or myofibroblast is called desmoplastic change. And the word desmoplastic change originates from the Greek, from desmos. It means knot or bond, and formation, desmoplastic change. This is also seen in breast cancer, especially in invasive ductal breast cancer, or NOS, by the definition of the WHO. And here you can see the image of the radiologist. This is a tumor. This is a tumor on histology. This is a tumor microscopic finding, and surrounding the tumor cells, a lot of activated myofibroblasts. And these switch from the silent fibroblast to activated or cancer-associated fibroblasts is also responsible for that feature here, and also for the nodular growth of the tumor itself. Because if you compare the invasive ductal breast cancer to the invasive lobular breast cancer, there is no tumor formation here. And the radiologists know them very well, that the invasive lobular cancer is not very well seen on the screening mammographies, but the ductal ones, yes, but not the lobular variant of breast cancer. And you can see the alterations of the breast tissue in case of lobular breast cancer much more better on ultrasound, but not on mammography. And the alterations of the peritumoral stroma is also used in diagnostic pathology. Here, two cores from the prostate. Older men, and they have a suspicious digital rectal examination, suspicious for cancer. Only PSA was elevated only in a limited number here a little bit more. And these cores are different. And these tumor cells here are surrounded by desmoplastic change. This is an urothelial cancer within the prostate, and here you can see prostate glandular cancer, acinar prostate cancer. There is no peritumoral desmoplastic change. Once again, the alteration of the peritumoral stroma is used in diagnostic and also in differential diagnostic pathology, because these alterations of the peritumoral stroma is in almost all cases associated with malignancy. Not all, but in the majority of cases. And the desmoplastic change has also prognostic impact. Prostate cancer is well known that the tumors show no peritumoral desmoplastic change, and the prognosis is very good. I know I compare apples to pears, but good prognosis, no peritumoral desmoplastic change, but in that cancer, pancreatic cancer, overall survival 10%, there's a lot of peritumoral desmoplastic change. And if we go back to the squamous cell carcinomas of the lower female genital tract, we know that the benign cervical stroma express CD34. It's a vascular marker, but it's also expressed by the normal fibroblasts surrounding the cervical glands of the normal uterine cervix. And within the normal stroma of the uterine cervix, you have no SMA expression, smooth methyl actin expression of the fibroblasts. The vessels walls are positive, but not the stroma cells. And if you go to an infiltrating growing tumor squamous cell carcinoma, surrounded by the activated or cancer-associated fibroblasts, there's no expression of CD34 or only a limited one, but an increase of the expression of SMA. So it means that the CD34 low and SMA high is a kind of stroma signature in cervical carcinoma. And this is also of prognostic impact. And tumors who have a complete loss of CD34, poor prognosis. Low expression or limited expression, better prognosis. Same here. If the expression of SMA in the cancer-associated fibroblasts surrounding the invasive growing tumor, if it is limited, better prognosis. And if there is a huge expression of the SMA within the cancer-associated fibroblasts, poor prognostic outcome. And desmoplastic change is also associated with an upregulation of HGF, hepatocyte growth factor, and an upregulation of the expression within the tumor cells of its receptor c-MET. And you can also obtain these features on diagnostic biopsies. We have done an examination of a little bit more than 130 cervical carcinomas in advanced stage, and we obtained these features only on a biopsy, not on whole amount sections, but on biopsies. And the pattern of invasion and the upregulation of these receptors and the HGF is associated with a pattern of invasion. I will come back to that in a minute. And the increase of the peritumoral desmoplastic change is also associated with adverse prognostic factors in cervical carcinoma. Here, for example, with peritumoral perineural tumoral invasion. And it is also associated, the peritumoral desmoplastic change, with a higher degree of tumor cell dissociation. And the tumor cell dissociation, similar to the tumor cell budding, and it's well known for colorectal cancer, is also present in other tumor types, and we called it here finger-like pattern of invasion. It means that larger tumor cell nests infiltrate the surrounding stroma, and this feature, when only small clusters of tumor cells or single tumor cells itself invade the peritumoral stroma, we call it spray-like pattern of invasion, and this is also associated with an increase of the desmoplastic change. It means desmoplastic alteration of the peritumoral stroma in the cases representing the pattern, is a spray-like pattern of invasion. And this pattern of invasion is also of prognostic impact in cervical carcinoma. And as I mentioned before, the pattern of invasion is a morphologic feature of tumor cell dissociation and similar to tumor cell budding, well known for colorectal cancer, as I mentioned previously. And the alterations of the peritumoral stroma is also seen in other cancers. Here in one paper analyzing oral squamous cell carcinomas. And here in these tumors, in the oral cavity occurring squamous cell carcinomas, if there is an antitumorigenic stroma, it means there's a lot of peritumoral inflammatory response, better prognostic outcome compared to those cases with strong peritumoral desmoplastic change. It means a lot of cancer-associated fibroblasts surrounding the tumor cells. And these are most recent data from our own group. The paper was published online on November 2nd of that year. And we have examined more than 430 primarily surgically treated squamous cell carcinomas, all of them macroinvasive tumors with no adjuvant treatment because they were included in the mesometric trial. I will come back to that later on, and is a prospective trial. And the features of the peritumoral stroma we report in routine pathology report for each case. So there was no re-examination on under study conditions. So these data represent so-called real-world data because we report the changes of the peritumoral stroma for each case since about 15 to 20 years. And basing on the routine pathology report, this examination was performed retrospectively. And there is also an impact of the peritumoral desmoplastic change on overall survival, limited or no peritumoral change, good prognostic outcome. Poor prognostic outcome if the peritumoral desmoplastic change was present. And if you grade the peritumoral desmoplastic change in absent, weak, intermediate, or strong, there's also differences in the overall survival for that cases. But once again, there are a mixture of different tumor stages in that study, and also cases with and without pelvic lymph node involvement. But if you looked, or if you compare conventional prognostic features of cervical carcinoma and the grade of peritumoral desmoplastic change, you can see that in that cases where the desmoplastic change is present, adverse prognostic factors appear within the tumors, and the grade of the peritumoral desmoplastic change is increasing with the post-surgical tumor stage. And if you look at the peritumoral inflammatory response and compare it to the desmoplastic change, there is a decrease of the peritumoral inflammatory alteration in cases with increased peritumoral desmoplastic change. So there is an inverse correlation between the antitumorigenic, it means inflammatory response, in the peritumoral stroma, and the protumorigenic desmoplastic change is associated with a decrease of the inflammatory response within the stroma of the tumor cells. So if we summarize that, the desmoplastic change is associated in squamous cell carcinomas of the uterine cervix, and preliminary data go in the same direction for vulvar cancer, with adverse morphologic features, poorly differentiated tumors, perineural involvement, for example, a decrease in inflammatory response, an increase of a tumor cell dissociation, a pattern of invasion or tumor budding, an upregulation of the HGF and c-MET system, and also the prognosis is much more better in cases when the desmoplastic change is completely missing within the peritumoral stroma. And the peritumoral stroma is also on focus in the group of the David Huntsman lab. And Rodrigo sent me these pictures. If you compare the serous cystadenoma and serous borderline and tumors, conventional type, to low-grade serous carcinomas of the ovary, there is an increase of the peritumoral stromal remodeling. If you look for FAP, it's a fibroblast activating protein, and it's increasingly expressed in the stroma surrounding the low-grade serous cancers compared to borderline tumors, and it's completely absent or only a limited expression within cystadenomas. That the desmoplastic change is also of impact in other tumors. We have seen in a collaborative study with the University of Halle, it's close by, Martin Kogel comes from, Blake, you know about that. And if there is an absent of the desmoplastic change in thyroid medullary cancer, sporadic one, and the capsule of the tumor is intact, you can prevent the nodal dissection of the patients. So the desmoplastic change is an impact on a surgical approach in thyroid medullary cancer. And this feature was incorporated in the most recent national guidelines to treat thyroid medullary cancer in Germany itself. Well, what about the remodeling of the peritumoral stroma? On mouse models, it has been shown that losartan is a drug used for the treatment of hypertension, and it is an antagonist of the AT1 receptor, lowers the number of the cancer-associated fibroblasts surrounding the tumor in mouse models. And it's also on effect by remodeling of the peritumoral stroma in other cancers. There's an increased perfusion of the intertumoral vessels if the tumors are treated by this drug, the losartan drug. There's a reduction of the hypoxia within the tumor, and because of the increased perfusion of the vessels, there's an increase of the chemotherapeutic drugs surrounding the tumor itself. And the stromal remodeling has also an impact on a preliminary phase 2 clinical trial on pancreatic cancer, because in patients treated with losartan and the FOLFIRINOX chemotherapy treatment, there was a higher rate of resection rate, and also the complete resection of the tumor was higher in the group of patients treated by losartan itself. So maybe in future that the peritumoral stroma is also a target for the treatment of tumors, and there is a switch from pro-tumorigenic, it means desmoplastic stroma, to the anti-tumorigenic stroma with a lot of lymphocytes surrounding the tumor itself. But yeah, let's see, the time will show if it is a good thing. Regarding that, and regarding the remodeling of the peritumoral stroma, one of our clinical colleagues, Benjamin Wolf, has in a 2-year sabbatical, so research sabbatical, at the Steele Laboratory in Boston, and we are working close together to examine the alterations of the peritumoral stroma. And we have used also a mouse model to see how the peritumoral stroma may be attacked by thalidomide itself. It's a well-known drug causing some malformations in pregnant women, and that's why thalidomide is not longer used for hormonal treatment and for as a drug during pregnancy. But we have seen if you implant squamous cell carcinomas, carcinoma cell lines, the HeLa tumor cell line, into mice. And if you treat them with thalidomide, there is a shrinking of the tumor itself. And maybe this is also an impact of thalidomide on peritumoral stroma and not only of the tumor cells itself. So let's summarize the things about peritumoral desmoplastic change and the remodeling. On histopathology, the peritumoral desmoplastic change is diagnostic features, mainly driven by cancer-associated fibroblasts. And there is an inverse correlation with stromal tumor infiltrating lymphocytes. And there is a positive correlation on the occurrence of the peritumoral stroma on tumor cell dissociation. It is a hallmark of aggressive tumors, not only seen in pancreatic cancer, but also seen in biliary cancer, which is also known for its poor prognostic outcome. And it's a negative prognostic factor. And probably the peritumoral stroma represents a possible therapeutic target to remodel the peritumoral stromal by a reduction of the cancer-associated fibroblasts. This is the research, and we have also to treat our clinical colleagues, to serve our clinical colleagues, and I'm serving here a huge ovarian tumor, and we had to go with that tumor to our autopsy room to weight it, and that's why I carry him with a serving trolley here, and it was a benign tumor, so it's just adenoma. And as Dr. Gilles has mentioned in his introductory remarks, sometimes the cooperation between the pathologists and the clinicians results in some publications. And I will come back to the total mesometrial resection trial a couple of minutes later. When we looked for a different approach to surgical treatment of cervical carcinoma, we went back to the state of the embryology. Here you can see a section through the pelvis of a female fetal pelvis of the 14.5 weeks of gestation. Here is the urinary bladder. This is a rectum. And this is a uterine cervix. And the cervix is surrounded by that connective tissue. And this connective tissue has a different appearance here compared to the mesorectum and also the meso of the urinary bladder. And this tissue is the so-called cancer field of that tumor, because the development of the uterine cervix is on embryology closely related to the surrounding stroma. And if you translate the developmental steps of the lower genital tract to the embryology, you can define the so-called ontogenetic anatomy. And during the ontogenetic anatomy, the collaboration between our clinicians and the pathology defines the so-called cancer field theory, and that it is necessary to remove the uterus itself and the surrounding embryology defined on embryology, that tissue surrounding the organ itself. And this is called the total mesometrial resection. It's a special surgical approach for radical hysterectomy, and the gynecologist in the room will know about the radical hysterectomy. And there's also a point of care treatment of these patients intraoperatively because we receive all first-line lymph nodes of the pelvis, and we examine these first-line lymph nodes on frozen section. And if there is a metastatic involvement of the first-line lymph nodes, there's a switch to radical lymphadenectomy. And this is called by our clinical colleagues by therapeutic lymphadenectomy. This is one part of the therapeutic lymphadenectomy. We look also at the resection margins of the radical hysterectomy specimen. It means a vaginal resection margin. And just in case if there is a mesometrial or parametrial involvement, we are looking also for the closest margin in or at the site of mesometrial involvement. And even if there is a small distance between the anterior or the posterior margin to the resection specimen, and if these resection margins are involved, there's a resection of additional tissue necessary during the operation procedure. And if there is an infiltration of the uterine corpus, it is suspected that the lymphatic drainage of the uterus changes from the lower pelvic lymph nodes to the parotid lymph nodes. And if we see on frozen section or macroscopically, there is an infiltration of the uterine corpus by the cervical carcinoma, there will also be a resection of the lower parotid lymph nodes. And these one we examine also on frozen section. And this is the second part of this so-called therapeutic lymphadenectomy. And this is an ad hoc analysis of roughly 100 cases. And in that cases, in 1/5 of these cases, the results of the frozen section has an impact on the surgical approach. It means additionally, the lymph node resection was expanded to radical, limited to radical. And in 15% of these cases, there was an infiltration of the uterine corpus. So the parotid lymph nodes were removed as well. And these both features were present in one case, resulting in expansion of the surgical approach. And the mean time, the mean examination time of all this stuff is about a little bit more than 20 minutes, ranging between 6 and 41 minutes, depending on the number of lymph nodes removed on the first line lymph node sites. These are TMMR specimens, and this is fresh ones, and we describe it and look for the resection margin at the vagina. Here it's a younger patients, the ovaries were left in the patients, but the fallopian tubes were removed to prevent ovarian cancer. And then we pin it on cork plates with pin nails, conventional pin nails, cork plates. And between the cork plate and the resection specimen, there is a paper tool to increase the fixation, because the formalin goes via this paper tool to the backside of the specimen. And we fix the specimen for at least 24 hours, and then we cut it definitely. And all these cases are included in the prospective total mesometrial resection study. And so I handle the cases in the majority of them by myself. There's a stamp in the lab, and this means please microscopic description and cutting, it's me. So these cases are reserved to me. And there, on this prospective study, Dr. Heckel has defined a so-called ontogenic tumor stage. And the definition of the ontogenic tumor stage was based on the ontogenetic anatomy. I showed you a picture about that of the female pelvis, and the ontogenetic tumor stage was retrospectively defined by our written routine oncologic report. And this was also published very recently. And when we go back to the embryology, we see if the tumor spreads within the female pelvis, there is a stepwise reactivation of a so-called previous Bauplan of the female genital tract. And as longer as the tumor grows within the female pelvis, there is an infiltration of additional structures of the uterus itself. And this is also true for exenteration specimens. This is a exenteration specimen, and the urinary bladder was tamponated by a paper towel to keep it in shape and to get these funny and well-preserved cuts to compare it appropriate to the MRI pictures of the radiologists. And the cancer itself, when the cancer goes within the pelvis, there is not also a stepwise reactivation of the ontogenetic so-called Bauplan. You can also call it inverse morphogenesis. And this is also proved if you look where the recurrent disease of cervical carcinoma is located within the pelvis. This is a heat map of a recurrent disease, and the majority of the recurrent disease occurs within the ontogenetic field of the female pelvis if the cancer ever recurs. And the ontogenetic anatomy and the surgical approach basing on the ontogenetic anatomy is also translated to treat vulvar cancer. And this special kind of radical vulvectomy is called vulval field resection. And there's also a point of care treatment by the pathologist, because we receive all vulvectomy specimens, and the specimen is marked by a suture at 12 o'clock for proper orientation. And we examine all resection margins of the specimens during the procedure. Here you can see it. There's a tangential examination, not a perpendicular one. And after examination of the resection margins, we pin these specimens on a cork plate as well and cut the specimen at least 24 hours later. And if you define also ontogenetic tumor stages in vulvar cancer, there's also a prognostic impact of the ontogenetic tumor stages in vulvar cancer, not only in cervical carcinoma. So to summarize this, cancer is an inverse morphogenesis, and there's an impact of the so-called ontogenetic field where the tumor develops. And this has also an impact on surgical approach. It was shown by rectal surgeons as well. They developed the so-called total, oh, there's a misspelling here, total mesorectal excision. And if you perform a proper total mesorectal excision and you remove all lymph nodes located in the so-called mesorectum, there is a lower rate of local recurrences in the patients. And in Leipzig, we developed the so-called total mesometrial resection for cervical carcinoma, the vulval field resection for vulvar carcinoma, and the lateral extended endopavine resection for recurrent or locally advanced tumors within the female pelvis. And the knowledge of the surgical approach was distributed by Dr. Höckel, my clinical colleague, by the so-called Leipzig School of Radical Pelvic Surgery. And he said better operations for better outcomes. This is Michael Höckel. And as Dr. Jilks has mentioned this, he achieved the so-called lifetime award of the International Gynecologic Cancer Society that year in November. And this is my last picture here. And we have also some fun outside of the working place to do some running. And this is a lecture given by Dr. Höckel in the UK. And sometimes we discuss some features by an espresso and some chocolate over there. And this is me in my office. And thank you for your attention. And I will be happy to receive some questions. Thank you very much.